Welcome to the University of Michigan Dentistry Podcast Series, promoting oral health care worldwide.
Today we are going to discuss the 3D lingual attachment of Wilson Modular Mechanics. And with us today is Bob Wilson, one of the co-developers of this system. Thank you for being here, Bob.
Thank you, Jim, for asking me.
First of all, I guess I'd like you to discuss the generic lingual attachment that you use in many of your different appliance designs, and then we'll talk specifically about the lingual arch. Why don't you begin?
We designed our lingual attachment to be used with all our lingual attachments, with all our lingual appliances, to have a twin tube, twin post locking mechanism. It's designed that as the posts are inserted in the twin tubes, it's held in by friction grip.
And these come in vertically, right?
And all the insertion is from the vertical direction. The reason being is for ease of insertion. And no matter how severely rotated or tipped the molars are, you can always see the occlusal surface. This one here has a lingual ball hook on it, and we usually recommend this be used for the upper molars, where the lower molars, you can get these without the ball hook.
Do those come separately like they are there, and you can put those on basically any appliance system that you have?
These come separately, and so one can weld them on with any appliance system. All of our appliances are designed to minimize any great changes one has to make in their own orthodontic system. And by coming from the lingual, we kind of let the orthodontist use his basic buccal appliance without interfering with the buccal appliance. If one is welding the lingual tubes on the molar bands, we suggest keeping a sectional wire or 1/2 of a lingual arch. And by placing this lingual tube on the wire with twin posts, it makes it very easy to take this to the welder and position it properly. The position of the lingual tube is in the middle, directly in the middle of the band, mesial and distal, occlusal, gingival.
Now, what kind of appliances do you have in your armamentarium? I know you've got a palatal arch, and you've got a lingual arch, and a quad helix as 3 major ones. Are there any others?
Yes.
How many?
Okay, let me show you up here. There are a number of different appliances, lingual appliances, and all of the different appliances here insert into the same lingual tube. And so you only need one basic tube. We have the lingual arch, which we'll be talking about here in a little bit. We have the sectionals. We have the multi-purpose adapter. We have our simple space maintainers. We also have some palatal arches like the Nance Holding Arch, our standard palatal arch, our quad helix expansion appliance, and our quad action mandibular appliance, and the multi-action palatal appliance. And the last one is our DYS module. The letters here mean do it yourself, which basically gives the orthodontist the twin posts on an 036 or an 040 wire, and one can design any type of appliances they want. And some people had requested that. All the appliances are designed that the twin posts are designed with the mesial post being the longer, the distal post being shorter, and we've done this to allow for ease of insertion. One can usually see the mesial portion of the tooth, but the distal portion is difficult. And once one inserts the mesial post, the distal post should fit in automatically.
Now, can the appliance be reversed if for some reason or another you wanted to reverse the transpalatal arch?
All these appliances can be reversed. It's the same tube, distal and mesial. It's the same size post, distal and mesial. So in certain cases, you may want to turn around a paddle arch, and you can turn a paddle arch around, or a sectional wire or anything around distal.
Now let's focus in on the lingual arch. And
The lingual arch is designed with the twin posts, the meso being longer. We have a distal extender, which is an 025 wire, which has uses of uprighting, controlling, and positioning of second molars. We have an activator portion, which has different angles, and it's been designed so one can make specific activations for extending the arch length or reducing the arch length or raising the anterior portion or lowering the anterior portion. The anterior portion through here is an 028 round wire. It's relatively light, but we can establish tremendous anchorage with this wire. The wire comes in 8 different sizes. And the activator loop here really avails you the ability of actually making it even smaller or larger than the largest or smaller size.
now, what is the ultimate goal as far as the fit of the appliance?
The goal is to produce a completely passive arch wire, one that is passive in the molar region, so we have passive molar torque, passive molar rotation. The anterior portion here should be lay passively right at the gingival border of the lower incisors, and usually the 4 incisors if possible. The wire should not be touching the bicuspid region.
Now, why at the gingival margin rather than at the cingulum?
If placed at the gingival margin, it maximizes the anchorage value that one produces. Also, it minimizes the patient playing with that wire or lifting it with their tongue. It just becomes more difficult to get at, and the ultimate effect is basically the patients literally forget it's there, and that's what you want, and not to lose anchorage. If the patient is constantly lifting the anterior portion of the wire, it will tend to rock the molars and loosen the molars and result in loss of anchorage.
Let's assume that you have used your measuring device and you have determined that size number 5 or 6 or whatever is appropriate for this patient. What's the sequence of adjustments that need to be made on this particular wire?
Okay. We have designed a definite sequence to make this very logical and very easy to adjust to make it passive. Once one has measured, it's best to take the wire and place it on your working model to see if you have approximately correct size. The tendency is to measure sometimes that half size longer than you really want. And my statement there is to normally take the half size smaller, because it's very easy, because of this activator loop, to increase the arch length. The distal extenders here can be removed or can be adjusted for uprighting molars. Normally, we bend these down and cut them off. And we bend them down in the same plane as the posts. And so we hold, protecting the posts, and just bend the wire down. And on the opposite side, I'm going to do the same. Bend it down.
Now, they're more than a right angle bend,
Yeah.
at least from what I can see.
Yeah, a little bit more than a right angle bend. We then cut the wire off to be just slightly shorter than the short post. And then when placed on the working model or the patient, one can take a Howell plier and just bend that distal portion around to conform to the band material, and then there's no tongue irritation.
Now you do that usually on either the work model or the patient as opposed to just freehand.
Yeah, I normally do that right on the model or the patient. So you can still have a nice elastic hook if you want to run thread to that, but you don't want that to irritate.
Okay. So the first thing that you do then is to decide whether you want to make the extensions functional or you want to remove them. That's right?
Yes.
Okay, what next?
Next, we go through a series of steps and adapting this so it is slightly constricted and passive. The first step then would be place it in your working model, put it in the mesial posts, and I hold right on the mesial post, and we insert. Yep.
Is this a Howell plier?
And that's a Howell plier or a utility plier.
Like a Weingart, something?
Yeah,
like
a
that?
Weingart that has a serrated beaks, flat beaks, and by holding that post, which are basically flat, one can control the torque and rotation very easily and without it slipping. The first thing we look for is the position of the activator and the tissue.
Now, by the activator, I'm assuming you mean the adjustment loop.
Yeah, the adjustment loop. And there is a 15-degree offset from the plane of the post to the plane of the activator, or the adjustment loop.
Presumably to keep away from the gingiva.
To keep away from the gingiva. But occasionally you have to modify that slightly. You may have to increase or reduce that. In that bending of the wire, one should never bend between the posts. All the bending should be in front of the posts. So the first adjustment we do is on both sides, evaluate the position of the activator to make sure it doesn't impinge upon the tissue, approximately 1 millimeter away from the tissue.
Okay.
And so in this, I'm going to have to hold it just in front of the activator and just push it away from the tissue slightly. When I do that, the opposite side of the wire is going to go up, and so you have to then hold just mesial of the activator and also bend up slightly. So you have to make actually 2 bends to effectively move that away from the tissue. So we would do the one side, and then would come back and insert the opposite side, and again check the position of that activator. From this point on, one should never have to go back and change that.
Okay. You're just using a scaler to get that up?
Yeah. To remove the wire, we go between the 2 posts, and just with a heavy scaler go between, and we kind of roll the wire in, and that will, remove it. Or you can go from the occlusal surface and use the occlusal surface like a fulcrum, and it should come disengaged. The next step is to constrict the arch wire slightly in the canine region.
When you talk about constriction in the anterior region, what do you exactly mean?
It means constricting it in the canine region a couple millimeters, which will reflect itself in 4 or 5 millimeters in the posterior region. And so what I have done here is I've just marked in approximately the canine region, and I just over-constrict.
Now, why are you doing this over-constriction?
Because as we make our anterior modifications and widen or flatten the anterior portion, the posterior section will get wider. As we make some adjustments on our molar rotation, it will tend to widen the arch also. And it's very important that all these lingual appliances maintain a slight constriction all the way to the very end, so that one is able to adjust these to make them completely passive. Expansion puts pressure, and you don't know where all that pressure is coming from. Mm-hmm. So we've over-constricted this. Normally, the arch form is with a narrow anterior portion when you begin treatment, and we've designed the wires that way. With this particular model that I'm using today, this is basically a relatively final arch form where the anteriors are flattened more, and I will have to do some adjustments in the anterior. In a situation where the mandibular incisors are lingually locked, the wire maintains an arch form like this, and we just touch the lingually locked laterals. There's no need to go and contour this wire to touch the labally placed or lower incisors, lower centrals. So we constrict it first. Then we're going to come back and place the wire in and adjust the anterior portion so it touches the 4 incisors or at least the 2 laterals.
Are you doing this one side at a time?
Well, initially, initially we do the same thing right side, left side all the time. Here, right now, we're just doing this, the front. So I just take a square part of the bird beak and just basically just flatten it off a little bit, and that's usually 3 or 4 little squeezes. And then as I take it to the model, we check to see if it touches or would touch the 4 incisors. It should not touch the bicuspids. And as you see, when I've just done that, now I am a little bit expanded. Mm-hmm. And if that's the case, I go back to that canine region and maybe constrict just a teeny bit more, just to maintain that slight constriction in the molar region. The next step is to place the wire in and check the molar torque, or we call leveling, which means if we put one side in and insert one side into the lingual tubes, that the other side should be level. If this other side is level, it means we have passive torque on the side that's inserted. On this particular case, this goes down just a little bit. So what we're going to have to do is raise it up so it's level. So we go back to the side that was inserted, and we have to make the determination where we make this change of torque. If the activator is properly placed just a millimeter away from the tissue, we adjust this from just in front of the activator, then we don't change this activator-post relationship. And that's what we're going to do here. So we take the arch wire here, and this was low on this opposite side, so I just take and just raise it just slightly.
Again, your goal being a passive appliance.
A passive appliance, passive torque. So I reinsert, and now you can see it lays at the exact level where it should be positioned. Then I insert the opposite side and do the same thing by removing the side that was just inserted, and again see if it's level. In this case, it's level. Mm-hmm. Most often you're going to see it go down. Okay, and then you adjust it up. So again, it's level. If by taking this side out, what we're saying is this side has passive torque if it's level. Mm-hmm. Later on, if you want to make this active, you can very easily torque these molars or rotate these molars. But it's very important to start out with everything passive, then you know how much your activation is. The next step is to adjust for molar rotation. And in this case, since this side is inserted, what we're going to do is try to line the posts on this opposite side up with the tubes. and then would have passive rotation on that side. By pulling the wire forward, you can see we can line these posts up over here. And by watching the wire as I do this, you can see it bends about right there. And so the wire really tells you exactly where to bend the wire. So we're going to come back to that point and essentially do what I'm just doing right now with this. I'm going to bend this portion that way.
So you're really just fine detailing this?
Just fine detailing. So I'm going to hold right in front of the activator and just do a little of adjustment. I just move that forward. And now as you can see, now the posts basically line up. We do the same thing on the opposite side. We insert that side, take this side out, and that goes back just slightly also. So again, I do the same thing. I'll bring that forward, try to line up those posts and tubes. And again, if you watch the wire, we'll see it bend someplace about there. And we just make a slight adjustment. You can see there's a slight adjustment. As you can see here, in the process of flattening, correcting molar rotation, I'm going to put one side on and leave the other side out. I'm just slightly expanded. And if that happens, then you come back again and just slightly constrict in the canine region. That's why the initial constriction is very important. If you do that properly, you really don't have to be, doing too much with this later on. So when you put the one side in, the other side should lay there right next to this other wire. If we take this other side out, this should lay right next to the wire. And what I'm going to do here is just widen it just as I just over-constricted it. Okay, and you can see here that the posts and tubes line up perfectly. And that tells you that there's passive molar rotation, passive torque on that side. The last thing we'll have to do then is position this wire against the incisors.
Now what kind of adjustment do you do there in the activator?
Okay, we do that in the activator portion. With the activator design, we have 5 different angles. And by knowing which angle to make your adjustments at, you can determine if you want to lengthen or shorten the wire or raise or lower. And all the adjustments are made by using a normal bird beak plier or light wire plier with a square beak goes inside of a bend, the round on the outside, and then everything's a little squeeze. The adjustments are normally 1 millimeter or less, minimal adjustments. And so the 4 basic designs, or adjustments here, is for lengthening, shortening, lowering, or raising. And this last adjustment I mentioned on the wire that we just made would be a little adjustment right there, very gentle on the right side, left side, and would lower this wire down so it touches right at the gingival border.
So at this point then that you have a passive lingual arch?
Yes.
Okay. Now,
on the model.
On the model.
Yeah.
When you transfer this to the mouth, if the model itself is accurate, I take it it's not a big problem.
If you take it to the mouth, it should be very close to being passive. But you may have to do some fine tuning. And essentially we go back through the same steps that I just went through, except we don't constrict in the canine region. We check the shape of the anterior portion, and then we check the molar rotation, and we check the torque.
Okay.
And the last thing would be then to lower the wire to make sure it touches right at the gingival border.
I happen to be a very big fan of doing things indirectly to try to save chair time. And I know that you have a rather interesting way of taking impressions for the indirect fabrication of the appliances. Will you please demonstrate that for me?
Most orthodontists, prefer to do as much work, away from the patient, and then, chair time is maximized. And we developed our transfer system to produce extremely reliable, accurate working models. We, with this, have done away with the necessity of having to remove bands, re-cement bands for soldering, resoldering, or removal appliances. In all cases, your bands can be cemented and never have to be removed. The important one point that I'd like to make on this, if one is using a paddle appliance, that the seating of the band should be way down on the gingival on the upper arch. Mistakes. Some people just don't ever seem to seat the gingival, the lingual portion of the band, or the paddle portion of the band, correctly. They should be way down so the gingival portion of the tube really almost touches the tissue. It almost touches the tissue. Then the occlusal portion doesn't interfere with occlusion.
Now you're looking at a work model there.
This is working on the working model. So I'm going to come back, and for demonstration purposes, this is our patient.
Okay.
Our bands are cemented in place.
This is prior to anything being done, impressions or anything else.
Yeah, before anything's being done. The patient could have appliances on for a year or two or whatever, and we desire a lingual or a palatal appliance. We take boxing wax, and if you use red boxing wax, fine, you can see it. And we fill the tubes with the boxing wax, and then we have these transfer inserts. It looks right there, these transfer inserts that have the twin posts, which are similar to those on the appliances, except these posts do not fit in with friction. They're supposed to slide out friction-free. The wax, or the boxing wax that we put in the tubes, is what is going to secure temporarily the insert from falling out. And so back here on the model, what we do, in the patient, we take the boxing wax and then insert these the transfer inserts into the lingual tubes and add a little extra wax on the outside to make sure it holds it in place. My recommendation then in the impression tray is opposite, from where these anterior teeth will be positioned in your tray, to take a rope of boxing wax and run it around in there, because it gives you an anterior seat also. Mistake a lot of people have made in the past is when they took the impression, they felt it wasn't going in properly, but it was getting hung up on these inserts.
I notice also you have a piece of dental floss attached to one of these.
Yeah.
You recommend that?
I recommend the little piece of dental floss be placed, and just in case you have a patient who decides who wants to try to eat one of these.
Okay.
And I recommend this with all paddle appliances also. So we place this so there is enough room under the occlusal so that the alginate material will flow properly. We take in our alginate impression. We remove the alginate impression, these will come out vertically. And that's another advantage of having the vertical slots, is that you can take a vertical impression. When we take this impression out, and I recommend alginate, you will see that the two posts stick out of the impression material. And so the two long posts that we have here are sticking out. Then we have our 3D lingual tube with a portion of band material.
Now this is separate. This is not for the appliance to be, it's not going to be part of the appliance. This is
No.
simply another transfer mechanism.
Yes, there are two pieces to our transfer system. And so this comes with a lingual tube and a portion of band material, and we bend these in so they maintain themselves later on in the plaster. And again, we take and put the boxing wax in the tubes, and we take these and place these on the two posts that stick out of your impression.
Okay.
And we do all that on the opposite side, and then we pour up our plaster impression. And this is what it would look like. Where lingual tubes properly placed, and now it allows us to have very accurate position of our lingual attachments. And so then when we fabricate our lingual or paddle appliance and then return it to the mouth, at a fabricated appliance to the mouth, there should be minimum amount of adjustments to make. Once one is finished with the alginate impression, you can remove these from the alginate impression, sterilize, and reuse them. They can be used again and again and again. The transfer lingual tubes can be reused again and again and again, just removed from your working model.
Sounds like a great system.
And it really is a time saver.
Sure.
And that's the whole reason for it.
Now, there's one part of the appliance that we have talked about already, but we haven't talked about the use of it very much, and that is the extender part of the appliance, going distally from the first molar. You've talked about this as being an auxiliary appliance for uprighting second molars, and I'm sure you can think of other uses besides that. Can you describe reasonably briefly how this is used and how this could be used as an adjunct for uprighting second molars?
Okay. That distal extender that we initially, was quite long, and I recommended bending down and cutting off. In this situation, we're going to use that entire length and fabricate a simple spring for placing pressure on the second molar. It's a simple process of making a loop that comes down and comes back up. And when we bend this loop down, it's bent in the same plane as the activator portion, which is about a 15-degree offset, so we don't impinge upon the tissue. And so this loop, you can see, comes down 3 or 4 millimeters, comes up 3 or 4 millimeters, and then this portion of the wire goes across the occlusal surface. And I put a little contour to contour the occlusal surface.
Now, do you ever put any sort of attachment on the second molar?
Okay. Normally, an impacted second molar, mesial impaction, will place a dead nam cleat, which is a long molar cleat that one normally puts on his molar. We bend the ends of that cleat up and make a nice hook, and then we weld some mesh to it.
Is this on the occlusal surface or on the buccal surface?
It'd be directly in the occlusal pit, if possible.
What happens if you have problems with the occlusion?
If you have problems with the occlusion with the upper second molar, instead of putting the hook on or making a hook, we just put a mound of bonding material like Concise, and right on the occlusal surface here, before that bonding material sets up, we'll just make a little hole in there with our scaler, and then the end of this wire will be bent to kind of hook into that little hole.
How far would you activate the spring at any one given time?
The normal activation is 1.5 millimeters per month, which means in most cases it's done in 3 or 4 months. One of the things I like about having the hook is that one can also put an occlusal force in. A lot of times, besides being impacted mesially, they're submerged, and so you can put that force can be distal and occlusal.
In summary, what are some of the important considerations you want the practitioner to remember in using this type of lingual appliance?
I think most of all is that the position is right at the gingival border and not up on the tooth surface someplace. The most common mistakes have been made by putting it on the tooth surface. So placing it right at the gingival border. Secondly, making sure your molar rotation and torque are passive initially. Then, if at some later point you want to put lingual crown torque or buccal crown torque or distal rotation, you can do that beautifully, very simply. But make sure you start out passive.
Well, thank you, Bob. I certainly appreciate the time you spent today. This is a fairly complicated sequence that we went through, but I think you've made it about as clear as can be, so thank you so much.
Okay, thank you, Jim.
You've been listening to a presentation from the University of Michigan School of Dentistry, which is dedicated to supporting open learning and open educational resources. This recording is licensed under the Creative Commons. It may be reused and redistributed for nonprofit use. Please attribute materials to the University of Michigan School of Dentistry and redistribute under this same license. For more information on how this and other University of Michigan School of Dentistry recordings may be used, visit www.dent.umich.edu/license.